My name is Rose Marino. I am a pediatric endocrinologist by training, and currently I am the medical director for the FOP program at Clementia Pharmaceuticals. And today we're going to talk about two rare bone diseases due to excess BMP signaling. The first one we will be speaking about is fibrodysplasia ossificans progressiva, also known as FOP, and multiple osteochondromas, or MO. So to start, we'll talk a little bit about what is FOP. So FOP is a rare disorder that's characterized by abnormal and irreversible formation of bone in muscles, tendons, and ligaments. And this bone formation is known as heterotopic ossification. FOP is an ultra-rare disease that is progressive and severely disabling and can be life-threatening and cause patients who have this to have shortened lifespans. The average lifespan of a patient who has FOP is about 45 years old. About half of patients have a reduction in the mobility around a joint after a flare-up when this heterotopic ossification occurs. And 15% of patients report complete loss of movement after their last flare-up. So the heterotopic bone formation is episodic and unpredictable, and the disability is cumulative and permanent because once they form this bone, it doesn't go away. So the predictable pattern of the HO formation is typically seen first in the dorsal, axial, cranial, and proximal regions of the body, and later in the ventral, appendicular, caudal, and the distal regions. But the problem is that the timing of HO formation is unpredictable, and it can be very difficult to predict when a joint may be permanently affected by the HO formation. So FOP is a genetic disease. It's familially transmitted autosomal dominantly, and it's caused by a single mutation in the ACVR1 gene that encodes for the ALK2 receptor, which is a BMP type 1 receptor. Most cases are actually caused by spontaneous mutations, and although it is autosomal dominant, because of the low reproductive fitness due to severe disability of this disease, there's actually very little familial inheritance. And 97% of patients have this same R206H mutation, although there are patients that have variants in the ACVR1 gene. So here is a schematic of the aberrant BMP signaling that's seen in FOP. So what you'll have are triggers, and those triggers can be any kind of inflammation, trauma. We talked about even a blood pressure cuff can be a trigger for a patient. And these triggers then cause the mutated ACVR1 receptor to become constitutively activated when activin A and BMPs bind. This constitutively activated receptor causes an increase in the SMAD1, 5, and 8 proteins to become phosphorylated. They then translocate to the nucleus and cause cells to go down the chondrogenic pathway and the bone pathway from there. So here's more of a pictorial view of the process of what happens when heterotopic bone is formed. So again, because of that genetic defect, when there's any sort of trauma in a muscle or in a ligament, the mesenchymal stem cells then transform into fibroproliferative cells. These recruited stem cells then are misdirected again because of that upregulation in SMAD to differentiate into cartilage, and then cartilage is then replaced by heterotopic bone. So why is FOP the diagnosis that you really don't want to miss? Well, it actually is very highly identifiable right from birth. So nearly all patients with FOP have bilateral malformations of the great toe. So you can actually see this right in the newborn period. And what these toes look like, as you can see in the picture, is that they're shortened and they're bent inwards, and they could resemble a bunion. If you do an x-ray of the feet, they show monophalangism, where unaffected toes actually have two bones. So if you actually get an x-ray, it's also helpful in the diagnosis. But there are other clinical observations that are seen in patients with FOP, and these include the flare-ups, which are soft tumor-like eruptions, the heterotopic ossifications that we just spoke about, In infants, you can see scalp nodules and neck stiffness, in addition to those toes. And you can even have minor skeletal malformations like brachydactyly, and hearing loss is also very common in these patients. So just to go into a little bit more about the flare-ups in FOP. So again, these are sporadic episodes of painful soft tissue swellings that may be mistaken for tumors. And these flare-ups, again, can occur completely spontaneously or after some inciting event, like a trauma or an immunization or anything like that. So again, these are often mistaken for tumors. They can actually develop very rapidly. They're actually very painful. In the infants, again, they can appear as lumps on the scalp. They can be red and warm to the touch, and they often resolve without treatment, and they may migrate to other sites. And really, the only treatment that is given to patients during these flare-ups are medications that decrease the inflammatory process. So those would be NSAIDs and burst steroids, which sometimes help and sometimes do not help. So again, why is it important to diagnose early? Because again, it's progressive and severely disabling nature that is often caused misdiagnosis, and this misdiagnosis can cause morbidity if inappropriate procedures are then obtained for these patients. You can then also take preventative measures and precautions to help keep those flare-ups from happening. So in a survey that was done of almost 270 FOP patients, about 2/3 had unnecessary and potentially harmful invasive procedures, and about 68% received inappropriate therapies. 36 patients reported surgical removal, and actually you never want to remove the bone in FOP patients because it can incite more flare-ups and more bone. So you typically leave the ossifications alone if you can. 14 patients and 7 patients reported chemotherapy and radiotherapy respectively because of misdiagnosis. So in summary, FOP is progressive, it's severely debilitating, and can be life-shortening. It's caused by the mutated receptor in the BMP pathway, which becomes overactive, sending signals that result in heterotopic ossification. Bone forms in abnormal locations, such as muscles, tendons, ligaments, and they effectively imprison patients in a second skeleton. The bilateral malformation of the great toes present from birth. They're almost always present in patients with FOP and can be an early identifier. As we just talked about, misdiagnosis and delayed diagnosis can lead to morbidity or death through the use of inappropriate procedures. All right. Any questions on FOP? The infusion? Bisphosphonates have also been used for some patients too. Yeah. Mhm. Yeah. 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 So we've seen that in some of our patients. Doesn't really work. No. But if there's bone pain, sometimes that sort of helps. And even, yeah. Yeah. So now moving on to MO. So multiple osteochondromas, which may also be known as multiple hereditary exostosis, is characterized by the development of multiple benign tumors called osteochondromas. 70% of patients who have MO have an inheritable form, which is autosomal dominant. 30% of patients, it's sporadic. And the autosomal dominant form is a loss of function mutation in the EXT1 or EXT2 gene, which is found in over 90% of subjects. The prevalence is 1 in 50,000, and the median age of diagnosis is about age 4, and it is irrespective of race, gender, or location. OCs develop when the growth plates are active, and they can result in joint deformities, functional limitations, pain, and short stature. And even though MO is a disease of childhood, the clinical sequelae can last well into adult, because again, once the OCs are formed, they don't go away, unless their treatment occurs, which is usually surgical excision and deformity correction. as of right now, there's no pharmacological treatment available to prevent the osteochondromas from forming. So here's a model of the OC formation from the excess BMP signaling. So the EXT1, EXT2 gene code for a glucotransferase, which allows the heparan sulfate chains to get bigger. And so when you're missing that, these heparan sulfate chains are truncated. So when you have the truncated heparan sulfate chains, there's more availability for BMP binding and signaling. And just like in FOP, there's an increase in the SMAD1, 5, and 8, then translocate to the nucleus to target genes involved in osteochondroma formation. And where these cells are located are around the perichondrium. So in an actively growing growth plate, this is where you're going to see these osteochondromas form. So again, these are benign tumors that, again, arise adjacent to the growth plates. So you can kind of really see them here. They're very dramatic. So you've got an OC here, and here, and here. And they can grow to be very large and actually can go through the skin and can be quite large and painful. And patients can develop all sorts of orthopedic problems, including deformities, malalignment, and limitations of joint movements. And again, pain from impinging and compressing soft tissue and nerves. It can cause leg length discrepancy if it happens at the level of the femur, as you can kind of see here. When osteochondromas form around the forearm, you can get deformities and functional limitations. So the little boy on the left has no longer the ability to pronate and supinate his forearm because of the OCs. So the clinical presentation of MO is really not just one OC, but most patients have multiple OCs, somewhere between 5 and 20 different sites in about 2/3 of patients. And about 20% have more than 20 sites of OC. And as you can imagine, the higher your OC burden, the greater your risk for deformities and limitations. And the common sites for OCs include your hands, your distal femur, proximal and distal tibias, proximal humerus, distal radius, and ulnus. And the common joint deformities are knees, ankles, and wrists. And again, as you can imagine, because these are occurring around the growth plate, the majority of patients have short stature. They also require multiple surgeries for the deformities and correction. They have pain, again, interfering with function and quality of life. And women can actually have concerns about birth because if the OCs form around their pelvis, that can cause complications. And although these are benign, they can transform into osteosarcomas in adulthood in about 1 to 5%. So again, the current treatment strategy is surgical removal. And not just once, but usually patients require several surgeries over the course of their lives. And again, although it's a disease of childhood, as you can see in this slide on the left, that adults actually also require multiple surgeries even beyond childhood. So again, the summary is, in terms of MO, is that again, it's a disease of childhood, but having clinical sequelae that last into adulthood. It's caused by an autosomal dominant loss of function mutation in EXT1 or EXT2 that result in the osteochondroma formation. The osteochondromas form on the surface of the bone near the growth plate, and although they're benign, 1 to 5% can transform into osteosarcoma, usually in adulthood. And the current treatment includes surgical removal. And that's it. Thank you. No, they just happen. They spontaneously happen. Yeah, it's not a trauma inciting. It's the growth. So it happens during periods of growth. It's around the growth plate. Yeah. And the average age is 4, but it can, I think patients have been picked up as early as 1 and 2. Yeah. So. No, once it's gone, but others form. Yeah. So that's the problem. Mm-hmm. Yeah. Yeah. It's actually a little more common than FOP. Yeah, there's about, for FOP, I think the quote is somewhere between 1 in 1 to 2 million. 1 in 2 million is the prevalence. Somewhere around there. 1 in 1, 1 in 2 million. So, rare diseases.